Yeah, okay. So welcome all and good morning. And basically, as a cornea specialist, we do see different types of complications following surgery, which are referred to us. So today I would concentrate on endothelial problems following cataract surgery, which basically I have experience in my practice. So the first issue that I would discuss is that when we have patients who had cataract surgery and come with post-cataract corneal edema, some of these could come immediate post-operatively. We could also have late corneal edema, which comes a few weeks after surgery, and then we could have edema which may come years after surgery. So I'll show you some cases that I have managed in my clinic and look at some diagnostic algorithms how to treat these patients. Before we start, a little bit about physiology. In the normal cornea, there is the endothelial pump, which is very active. In patients with raised pressure, the pump is active, but you see epithelial edema. In patients with bullous keratopathy, where the pump fails, you will have corneal stromal and epithelial edema. And in patients where there is hypotony and the pump is inactive, you will just get stromal edema, but no epithelial edema. Keeping this in mind, if you have a patient who would walk into my clinic with a referral of early onset corneal edema, I normally try to look if it's a patient who has a diffusely hazy cornea, which looks mainly epithelial edema, I would consider raised intraocular pressure. Whereas a patient with no epithelial edema with a very hazy cornea, it could be a patient who has hypotony or wound leak. And another patient where there is a diffuse edema involving all the layers, I would also look for presence of inflammation, raised pressure, or a dilated pupil, which could suggest a toxic anterior segment syndrome. However, in the absence of this, it might indicate there is an endothelial injury. I normally look at the other eye. If the other eye shows a bad endothelium, probably this could be a response even following an uneventful cataract surgery. However, if the other eye is fairly normal, it indicates there has been some sort of endothelial trauma during surgery. And if the surgeon mentions that the surgery was uneventful, this could be something related to a toxic pathology. However, in presence of an eventful surgery like a hard cataract, small pupil, or a shallow AC, we can understand that there may have been endothelial problems during surgery. A descent membrane detachment can also present very similarly with diffuse edema. However, if the edema is localized to one area of the cornea, I would like to see whether the margins are distinct or indistinct. If the margins are indistinct, it indicates there is endothelial trauma. While if the margins are very sharp, it might signal a descent membrane detachment. So most cases of early edema we know resolve with medical management and rarely surgical intervention is required. But one of this situation is a descent membrane detachment. I'll show you some cases of descent membrane detachment. So when you look very carefully at these cases, what you realize is that there is a very sharp distinction between the clear and the edematous cornea, a sharp margin, as I mentioned, which is very strongly suggestive and should make you suspect of a descent membrane detachment. If you cannot clinically pick up, you can do an OCT, which might help you to distinguish it. And a very important factor is to look whether these are planar detachments or non-planar. That means how much is the gap between the stroma, descents, and the descents membrane, and also look whether this is a detachment, whether it's a tear, whether it is scrolled or not scrolled, and what area is involved, and what is the size of the area of detachment. Based on these, one would determine how you would treat a patient with descent detachment. Depending if it's a large and total detachment, a non-expansile concentration of a gas air bubble would be the best. Similarly, if there is a edema which involves the central or the inferior cornea, gas bubble would be best. However, if you have superior detachment, an air bubble usually suffices to reattach the cornea. A small peripheral detachment or a very shallow detachment can be left alone because they may usually reattach on their own. Similarly, if you have a scroll tear in the periphery, it's best to observe them. A large central scroll tear is a very difficult situation, and in some situations, you might have to do an endothelial keratoplasty. Transcorneal suturing and EAC-TI are other modalities that might sometimes be required. Before we proceed further, seeing some of these cases, just to mention that we know the descents is about 5 to 515 microns and an OCT, and consists of the anterior fetal layer, which remains constant with age, and the posterior non-banded layer, which thickens as we get older, and we have the interfacial matrix which glues the Descemet's membrane to the corneal stroma. As we get older, the Descemet starts getting thicker, and patients with Fuchs dystrophy may have extremely thick Descemet's membrane, which can sort of also help you know, for example, if you have a patient with the Descemet membrane detachment, whether how is the Descemet's thickness. Now, why do we get a Descemet detachment? We know that the Descemet thickens with age. It becomes sort of still thicker in Fuchs dystrophy, and the adhesion between the stroma and the Descemet reduces with aging, and therefore whenever we have a knife which is blunt, it is more likely to push the Descemets back rather than perforate or penetrate it. Similarly, while putting hydration, we can have a fluid wave which can detach the entire Descemets, and movement of instruments across can cause tears and problems. We also have a very small subset of patients who can get bilateral Descemet membrane detachment following cataract surgery. And in these patients, there is possibly an inherent weakness of adhesion between the Descemets and the stroma. And some of these can present even 2 to 4 weeks following an uneventful surgery. So the OCT not only helps us in documenting the Descemet membrane detachment, confirming the diagnosis, also helps us to understand the extent, configuration, and to know whether there is any tear or any loss of Descemet's membrane. And as I said, the thickness of Descemet's membrane can reflect whether the patient's endothelial status. Recently, a paper published by Dua et al. Showed us that the Descemet membrane detachment on OCT could be of 3 types, where you have the Descemets and the Dua's layer detached, which is taut and tight. You can have a Descemets alone, or you can have a splitting of the 2 layers. So this was one of the image I posted many years back in the Cornea Society, where I thought this was a splitting of the Descemet's membrane. So I'm not sure if this is splitting or this is really the Dua's layer. This is a patient where OCT was done and can show that the UBM also showed that there is a significant loss of Descemet's membrane in the central cornea. However, we still went and put an air bubble, because if the peripheral or the mid-peripheral corneal endothelial reserve is good, these patients can clear up. So despite loss of a large area of central Descemets, the cornea can clear up. So do treat these patients even if they look bad to begin with. This was a case where there was a viscoelastic which was injected for doing capsulorhexis, resulted in a Descemet detachment total, and the Descemets is seen sticking to the lens. With some experience of EK, I did a double full thickness tab incisions. The viscoelastic was very slowly expressed, and a gas bubble was put, and the Descemets reattached eventually. Sometimes you might need to put transcorneal full thickness sutures in some difficult cases which fail bubbling once or twice. And you may also have patients where there are adhesions where you need to roll and release them before you inject a gas bubble to make the Descemet supple and reattach. And sometimes you can have Descemet scroll like this right in the center, causing some decrease in vision, but the cornea is now crystal clear and you have to accept the situation. Sometimes when you have a total Descemet detachment, I do an inferior YAG PI so that I can put a large gas bubble and don't get pupillary block. And miraculously, in some few patients, I've had the Descemet reattached when I called them for the gas bubble injection. Tractional Descemet detachment is not common with cataract surgery, but you can get it in very inflamed eyes. And sometimes we have a situation where we have synechia to deal during surgery. So if you have thick synechia with a lot of fibrosis, it's better to cut it rather than try to separate them, which may cause a Descemet membrane detachment. One of the problems with injecting air and gas bubbles are that the hydrophilic lenses can opacify following these procedures and can be a big problem after, once they cause visual loss. Another problem which might happen for early corneal edema is toxic anterior segment syndrome. While it's most common with chemical residue and enzymatic cleaners with various fluids and medications that we use during surgery, a new problem is because of use of intracameral antibiotics. Either they are not mixed properly, or they may be having additives which are not safe for the corneal endothelium and the uveal tissue, and you get severe inflammation. I would now share with you some cases of late onset post-operative corneal edema. So let's see if we have a late onset edema, how would you manage these cases? If the corneal edema mainly involves the inferior cornea, one should think of a retained fragment of the nucleus, the epinucleus or the intraocular lens. However, in patients who have old corneal pathology, you know their cell counts were low when you operated. It could be a slowly progressive corneal edema picture. Patients who have had chronic inflammation or they had a complicated surgery, either because of a poorly placed lens or they have vitreous disturbance or they have a sort of glaucoma with chronic inflammation. So these are patients where they might slowly come down over a period of time with progressive cell loss. Now, if they started with a low cell density pre-operatively, they may come in the early post-operative period. However, if they started with a very good cell density, they might present as a late onset bullous keratopathy years after surgery. A sudden onset of corneal edema and keratic precipitates after uneventful cataract surgery should also one consider viral endothelitis, because they respond very well to antiviral plus steroid. However, if the condition continues to recur and is refractory to steroids or recurrence is there, one should always rule out a low-grade endophthalmitis like a P. acne endophthalmitis in these patients. And as I mentioned earlier, you can also have late onset Descemet detachment in some of these patients. A very rare cause of late onset peripheral edema is the Brown-Mclean syndrome. So I'll show you a few cases in practice. A retained lens fragment, you need to have a high index of suspicion. They do well in the early few weeks, but then start getting recurrent inflammation, raise pressure. And if in doubt, do gonioscopy, slit lamp examination, UBM and OCT, and you need to remove them as early as possible. UBM has the advantage of showing you not only the fragment, but also the mobility of the fragment. Similarly, you can get like this patient had an intraocular lens fragment or a loop fragment, which was left behind following an IOL exchange. And we floated the fragment out and the patient recovered with a clear cornea because we intervened early. However, if you wait, you are going to get failure. This was an unusual patient who had an iris coloboma, was referred. I saw a Descemet scroll at 6 o'clock with inferior corneal edema. I expected him to recover spontaneously. However, on follow-up, he continued to get worse and the edema continued to progress. The Descemet scroll appeared fixed on slit lamp examination at 6 o'clock. But it was only subsequently when I did a UBM, I realized that this was a floating Descemet scroll. So I had to take him into operation theater and remove the Descemet scroll. I did a little bit of anterior stromal puncture. And this is how he looked 3 months after surgery. His cornea has recovered and he's extremely happy. And as I mentioned, always consider a P. acne endophthalmitis when you have something which looks a little unusual. Brown-Mclean syndrome is a very specific entity which can come after any form of cataract surgery. Originally, it was after intracapsular cataract extraction, where you get peripheral corneal edema, pigment dusting on the endothelium. The central cornea is spared for many years, and very often you can get away without doing a surgery in these patients. The etiology is still not very clear. And therefore, it's very important that you want to avoid all these situations. We need to evaluate the endothelium well preoperatively. A good slit lamp is essential to not only look at guttate changes, Descemet's thickening, and pigment dispersion on the endothelium. We also need to learn the specular technique of slit lamp examination. Although we may have a specular microscope, we need to look at guttate changes, which are excrescences on the Descemet's membrane. We need to understand that specular microscopy is often not helpful when you need it the most. So if you just look at the cell count, it can be erroneous, especially in patients with bad endothelium. And you need to look at the hexagonality, the coefficient of variation, and the presence of guttate changes, and not just the cell density, because it can mislead us totally. And unfortunately, in most patients with endothelial dystrophy, you don't get proper images and you cannot make a judgment. And therefore, the judgment is often clinical. So if you have a patient who has no epithelial edema, the pachymetry is less than 600. Pachymetry profile is normal. There is no history of morning blurring of vision. You could go ahead with doing a cataract surgery alone. Whereas if you have frank epithelial edema, you have a thick cornea and an abnormal pachymetry profile, possibly do a combined surgery. Understand that guttata itself can cause 1 or 2 lines of drop of visual acuity, and eyes with very poor endothelium are best left unless the cataract is really severe and there is significant visual loss. Dr. Sanjay Patel showed us that tomography can be a very good tool to pick up a very subclinical stromal edema and make a better decision of whether we do a triple procedure or we do a cataract alone. And we also have situations where it's very difficult to clinically distinguish whether we are looking at a patient who's got Fuchs dystrophy or whether we are looking at a patient who's got viral disease, because they may both present with corneal edema. However, in viral disease, we know there will be a history of red eye, there may be a history of recurrent eye problems, there will be keratic precipitates, there may be some subtle corneal scars, and the response to steroids and antivirals in a patient who has viral disease will help us to distinguish, because in Fuchs dystrophy, we don't expect any response to antiviral therapy. And the presence of iridocyclitis with a dull sensation will further strengthen our thought process regarding a viral etiology. So when we look at all these features, sometimes in unilateral situations, it helps us to distinguish what we are treating and make a better decision. So I would thank Ajanta Pharma and the All India Ophthalmic Society for giving me this opportunity to be here today to show you some of my cases of endothelial dystrophy. And I would like to say that please stay safe and take care. Thank you all.